kind of info letter I have distributed a couple of days ago, I think last week. But in this presentation, I'm going to discuss the details related to this and add some flavors. And the other thing I would like to declare is that on the same way, while I was presenting and preparing this presentation, there was a new publication published just like 2 weeks ago about a workshop which has the same or very similarity with what we ran, but it was a little bit larger. So the respondents from my survey was almost 20. For their survey in these 3 workshops, they had 54 participants, healthcare providers, the same distribution of hours, which is like it's included neonatologists, nurse practitioners, and respiratory therapists, basically. So it has a lot of similarities, but with some different details I will go through in the next slide. So the objectives, 3 main objectives. The first one would be simple review of the history, the local data here in HSC, and I would apologize about not presenting Symphonifis data, although I collected the number of the cases, but I did not have enough time just like to go in detail to the charts of the patients and have much further information. But I think it's going to be a primary start for the next work by the Lung Health Committee, and I will deliver all of this data I've collected to the Lung Health Committee to continue the work. The second object will be to speak about when to administer surfactant for spontaneously breathing babies who are on just non-invasive support. What are the criteria that we can tackle in order to define one united word among us as practitioners? And here there are 2 main things, which is the oxygenation criteria and the lung ultrasound criteria. And I have created a kind of algorithm or proposal that can be started and can be discussed among the rest of the team so that we can come up with some kind of unified criteria. And the third component will be the less invasive methods. I will present the results of that small simulation and the survey about the suggestion for premedication and which catheter to be used in the MIST or LISA. So just briefly, the history of surfactant, all the story started, let's say, in the 1929 as a concept of having something that called surfactant, by knowing that there's something called surface tension, which prevents the lungs of those babies from opening in the first breath. And then this was just like the ideas. So it was started just like 1929 and again emphasized in 1947. Dr. Avery's we can say work started from the 1950s, but you can say the point which changed the whole game was Kennedy's baby. I think all the people knows that President Kennedy lost his baby who was born at, I think, 34 weeks having RDS and passed away after 3 days. Just the next year, they started all the work about the synthetic surfactant. And then within the next decade, they started working about the natural surfactant. And then the discussion was about when to give, how to give it surfactant, single, multiple doses, all of these work and the research. So regarding the surfactant, I would start with a preg, which was surprising to me. If anyone knows the answer, please just unmute yourself and answer this. Did you know how was the first surfactant therapy administered in 1964? How did they deliver the surfactant? Anyone knows? Actually, naturally, I would say it's through an ET tube because it wasn't the same decade when they started the neonatal ventilation. But honestly, I was surprised that it was through aerosolization, which is now is the goal of, let's say, the end of the spectrum of the methods of surfactant administration. Now, all the people are now looking at the aerosolization of surfactant as the least invasive method for administration. So that time it was a synthetic surfactant that was applied, and they tried to nebulize it through the incubator itself. So just if you look at the history of our common illnesses in neonatology are so similar. You discover the thing, you start the treatment, and then you start thinking about how to prevent the whole illness by giving it prophylactically, as happened with the surfactant. Similar thing happened with the PDA. A lot of similarities how we are doing and progressing in the you can say, and we keep our discussion about prophylaxis and how to select the cases that require early treatment or late treatment. And then the conservative measures like, okay, just CPAP is enough, or no, you need the surfactant and you have to administer it earlier. All of these discussions are so similar in the history of neonatology with the common illnesses. And I found the PDA as an example similar to it. The local data at the HSC, which was presented already in the info letter, you know, that I collected the data from 2021 to 2023 in February. And I collected all the number of the cases that were given surfactant. And I just confirmed that my source of information was just the discharge patient list. And it was not a formal source of information, accurate information, but it gives an idea about how we did over the last 2 years. So the number of cases, as you remember, 111 infants given 150 doses. And there was significant variability about the timing and the method of administration generally for those doses. As I emphasized in that info letter, that we are still behind in providing the MIST or LISA, and there was some, I mean, like this ensure was still more common in providing the least invasive surfactant compared to the MIST, and we are aiming to improve the MIST rate. Generally, the most important thing that we are still doing it invasively in more than, I mean, 72% of the cases we are intubating the babies, connecting them to ventilators and giving the surfactant. And all of us, we know that the optimal figure will be more of a red, a little bit of a green, and the list to be the blue. But this is not the case all the times. But we can do something to improve this figure so that we increase the MIST. And especially speaking, when we talk about the less than 29 weeks gestation, we are still behind in the non-invasive methods. We are still at 85% of the babies, they are intubated, mechanically ventilated, given the surfactant, and then the extubation and the prolonged period of respiratory support goes on. Though that's the main message I can say, and I can tell that this is a basic data we have to work so that we can monitor after we implement a better practice. All we know that what we are using is a BLES, which is bovine lung extract substance. So it comes from farms in Ontario, being extracted and given and delivered to the babies. Generally, as also that info letter, it's mostly those babies on 34 to 37 late preterm infants receive highest number because they are the highest number of our babies in the NICU. The indications that were given surfactant for basically neonatal RDS, but other issues which is related to surfactant dysfunction, like meconium aspiration, sepsis, pneumonia, asphyxia, all those were among the cases. And actually pulmonary hemorrhage had a good portion from repeated doses, basically. Okay, now when we discuss about when to give the surfactant, basically, I can think of only 4 pillars, or can say collection of things that can define the criteria for surfactant administration. I group them into 4 groups. So clinical assessment, clinical scoring, severity of respiratory distress, oxygenation and the expression of oxygenation by FiO2, saturation, AA gradient, BaO2, a lot of things you can't put until this, it can say title. Radiological, and this will include the X-ray and the ultrasound, gestational age, and all the related risks, like speaking of antenatal steroids, chorioamnionitis, and sepsis risk. But for every single one of us, let's be open, I think there's one which is more prominent. And I think most of us will think of oxygenation as the most important collection of, let's say, pillar. Some of us may think or may consider as clinical assessment and the clinical scoring is more important. The severity of respiratory distress is more important for a baby who is on CPAP. Well, most of us and all of us would say that gestational age also is a very important factor. So yes, when the four group of findings are compatible, no one will discuss, okay, we need to give the surfactant. But the conflict is created when you have a good oxygenation, good radiological findings, but a poor severity score, for example, or an extreme preterm infant, very like 25, 26, who has good imaging, good oxygenation, and good even clinical assessment. You would say, okay, 25 week are not requiring surfactant. That's very weird. And you will regret if this baby develops something or will get worse beyond the 12 hours or 24 hours of age. And as we all know that RDS is a dynamic also illness. So just speaking of the clinical assessment and the development of the clinical scoring, we know that it started from the 1956 with the first paper from Silverman, where it was just a trial about using the water mist nebulization in treating those babies who have neonatal respiratory distress. And they tried to find a kind of measurement tool, and he started with this staging, describing the chest wall movements, and actually it's named retraction scoring. So the main criteria was the retraction, and even nasal flaring was described as like description of the chin, the lips, and how all this kind of movements are happening. And then it has been modified into 3 retraction things and nasal flaring and the grunting. Then Downs by 1970 came with another kind of tool to assess, and they correlated it with the acid base and the blood gas status. Downs itself, it has been modified, especially when you speak of the cyanosis and the FiO2 requirement. The last version, which is commonly now implemented in the ACORN, relies on the same criteria, which is respiratory rate, the retractions, the grunting, the air entry auscultation, but also the cyanosis expressed by the FiO2, whether the baby maintains the saturation of room air, or when FiO2 less than 30% or above 30% scores, like it would be 1 and 2. ACORN modified it further and increased and inserted, let's say, the 4th pillar, which is the gestational age in the criteria or in the classification of respiratory severity, which could be mild, moderate, severe based on the score. So when we speak of Downs itself, it's 4, 4 and 7, 4 to 7 and above 7. For ACORN, it's less than 5, 5 to 8 and above 8 is severe distress and may indicate even intubation. So those are the clinical parameters. I tried just to gather them all together. So if I speak of Silverman, those are in yellow. Some of them, all of them about retraction basically, and the degree of the distress itself. And we speak of Downs, it's quantifying, in addition to the retraction, reflecting on the ventilation, lung recruitment, when you speak of the FiO2, and when you speak of the gestational age, the baby's ability to cope with the distress. Those are the clinical parameters. Do we practice this? Honestly, no. We take our subjective clinical assessment. Okay, I can see that this baby is retracting, some grunting. I don't take all the consideration to say that there's a score. There were a lot of, you can say, trials trying to correlate the clinical severity with the need of surfactant administration. It makes some correlation, but it's not very high let's say, level method. So what are the, let's say, disadvantages or the confounding or the noise that can happen with relying on only one of those parameters? For clinical assessment, the tachypnea and respiratory distress can be caused by many things, especially when we are talking about preterm infants, extreme preterm infants, pain, handling, discomfort. All of those can give us a false respiratory distress, not related to the lung parenchymal issue. It's also, speaking of oxygenation, which parameter should we use? What cutoff value? And I mean, the causes, it could be related to something else, not related to the lung parenchymal RDS issue. The radiological findings, if we speak of the X-ray, all of us, we know that there might be delayed changes by about 6 hours. which means like there's a window of the surfactant, of the golden window for surfactant, which you could miss. If you speak of the lung ultrasound, the main weakness, it's a newer modality that some people still, they don't buy it in, although we are very dependent on the lung ultrasound in our unit, for example. The dynamics changes that happens with the lung ultrasound or with babies who are on a CPAP. And what's the score that we have to rely on? Although there are a lot of literature that can define which is score 8 or 9. Gestational age and its, say factors related to the gestational age itself and the developmental and embryological development of the airway, the presence of antenatal steroids, the other risk factors for having an RDS. Speaking again about the recent workshop RDS and workshop and the consensus they had, right? They suggested, based on that discussion and the surveys they have done, this kind of criteria to give the surfactant for babies who are on non-invasive. So we can see that they have used 3 of the pillars, basically. They have used the gestational age in order to classify the babies. They have used the clinical severity score in order to classify the babies. And also they used the oxygenation status. And there's no imaging pillar in this kind of criteria. It's not evidence-based, again, it's a workshop-based, survey-based, similar to what we have done maybe by somehow. They have added the blood gas. So for them, the presence of 3 of these 4 is an indication to give surfactant. When you speak about smaller babies, you have lower CPAP limit, you have lower FiO2 number, especially when you speak about the late, oh no, they are similar, I'm sorry, I'm just confused. So, but still with FiO2 30%. And here we speak about higher number for those who are more mature infants, higher number for the mean airway pressure on the CPAP. The survey results, briefly, I would say, I would present here the oxygenation discussion and the lung ultrasound scoring discussion. Oxygenation, so in a scenario where we have specific gestational age of like not so extreme preterm infant, CPAP +7, saturation is maintained. Which FiO2 is the threshold? 2/3 of us relied on the above 30%. And there's a good number who's still considering 40% as the threshold for 32 weeks. Some, which is also 1/3 of us, almost like, again, they mentioned that, okay, the presence of lung ultrasound will support this diagnosis or the surfactant administration with a FiO2 above 21%. So there's some variability in the FiO2 among us, which makes sense because really it's not a very good surrogate of how the oxygenation status is doing. It's just, if you think of it, something incoming, the lungs, and something outcome, which is the saturation or PO2. All I'm looking at is just the income, what's coming. So it doesn't give full picture. Lung ultrasound importance, still like, okay, we have good percentage who agree that lung ultrasound is very important factor in decision of surfactant for those babies spontaneously breathing. But still, there I can say like 5 and less are in the suspicious area. So still they are hesitant maybe to rely on the lung ultrasound score, which is, I mean, like all of us, we know that all the evidence now are suggestive that lung ultrasound is very helpful in offering surfactant earlier than later. Now, the role of gestational age also had a factor in impacting even like on defining which lung ultrasound cutoff I will rely on in giving the surfactant administration. For example, here is a baby who is on a FiO2 21%. When I can presume that is 24 weeks, most of us, like we gave surfactant, I mean, only maybe one was against, okay, there's no criteria for giving surfactant, but the rest defined different cutoff values for surfactant, and even like a score of 6 was suggested to be okay to give surfactant. And this drifted a little bit to higher scores, which is score 8 when we go to 26 weeks. And when we are 28 weeks, I'm not going to care much about the lung ultrasound. That's what's been, responded. And they would not give surfactant, even lung ultrasound score 10. It's not mentioned here, but the 10, nobody chose it. Again, for our practitioners, the lung ultrasound loses its importance in those who are above 28 weeks. And this thing, I believe it should be changed. Anyway, briefly, oxygenation in DSIS. It ranges simply relying on what we are providing or what we are providing at the same time. What we are receiving is saturation, so we call it saturation to FiO2 ratio compared to AO2 to F ratio, to FiO2 ratio, or no, including the pressures in the equation. So either you have to get the AA gradient with the old one. All of us, we know that it's the most accurate one to give the expression, but it's very difficult to calculate it each time. Simplified by the oxygenation index, then oxygen saturation index. And recently there is the SOPI, which relies only, it's similar to the oxygen saturation index, but here we use the PEEP instead of the mean airway pressure. What I want to tackle on is the SF ratio. Actually, and this idea about thinking of SF ratio as an index came from the adult medicine and the PICU, where they defined recently the ARDS, not just based on the Berlin PF ratio classification, mild acute lung injury or mild, moderate, severe ARDS. They use for those patients who they don't have arterial line, just saturation relatively to the FiO2, and they classified mild to moderate to severe. So I made all the possibilities for FiO2 down from up from 21% to actually I made all till the 100%, with the goal of saturation between 100% to 88%. I came up with this figure about the relationship between FiO2 saturation and the SF ratio, which takes this configuration. And here, this is the FiO2 30%. So when FiO2 30%, I have SF ratio in the range of almost 290 to the 300, I think, yeah. Anyway, I took it further. I made it as a table. I don't want to cause a lot of headache for you. I will make it simply. I tried to look for you can call it the breakpoints. I divided them into breakpoints. The first breakpoint, I found it 400. Then the next breakpoint is the 350. So you can see break 400, 400. Here 350, 350, 350. The next breakpoint is a 300, 300, 300, 300. And I divided this into zones. Zone number 1, which is the good zone, can give me an FiO2 between 21 to 25% with this range of saturation. Zone number 2 is the yellow. Zone number 3 is the faint red. Zone number 4, which is the worst, and below 300 is F ratio, is in the deep red. In other words, this F ratio can give me 4 zones. Benign zone above 400, which usually can accept the FiO2 21 to 25%. Zone 2, which FiO2, correlating to it will be 23 to 28. And then zone 3 and zone 4. And this, I tried to sort out this concept we have in our mind based on poor evidence, very weak evidence, that FiO2 30% is the cutoff. We can divide the FiO2 21 to 20 to 30% into more zones that allows us, convince us that there is an oxygenation impairment that required an intervention, either escalating the pressure support or providing surfactant. I tried to collect it with the PO2, I tried to mention how, because saturation and the FiO2 are dynamic changes. So if I come now and saturation is 90%, the FiO2 is 22%, I may come after 5 minutes because baby moved a little bit and required FiO2 25. How can I define, okay, this baby's SF ratio I will build my decision on is so-and-so. So I suggested a period of 5 minutes of stable saturation, and I would suggest it to be in the range of 29%, and I will have a go for this, with this fixed stable of IO2, and I will consider this number. There might be some other ideas to get a valid SF ratio, because as we said, they are dynamic parameters, they are changing every single second. But why I suggested the 29%? If we go back to this zone, we are accepting saturation in what we can define in the permissive hypoxia region, which is the permissive hypoxia that's acceptable for a long-term outcome. But when I speak about oxygenation status that I want to correct, I would not agree that, okay, this baby is a IO2, let's say 28 and is, or let's say 26%, and the SF ratios in 350, no need to give surfactant, for example, or no need to escalate my treatment. I don't accept saturation for 88% for that decision per se. Okay, so don't go in depth into this, but just like I want to emphasize that I would like, in order to calculate the SF ratio, to rely on a number which is above 92%, up 90%. I would suggest 92% as a good number. One more thing, because if we don't define this, I mean, it's useless. At the end, like if IO2 is variable, if I choose SF ratio, some people choose saturation of 90% to get the result. Some people use like maybe 88% or 94%. There will be variable decision making. And at the end, I did not make anything with this. So those are the zones. That's all I want you to come with. Like if we calculate SF ratio, I will have 4 zones. And based on that, I suggested an algorithm for giving decision about surfactant. Considering I don't have a long ultrasound, I took only one parameter from the antenatal history, which is the antenatal steroids, yes or no, if it's baby intubated or not intubated on the non-invasive, and I considered the CPAP level of 7 to calculate the SF ratio. So for intubated babies, preterm baby who has RDS, you will give surfactant. The baby has been intubated. But for non-invasive support, calculate the SF ratio. So if there is antenatal steroids, I tried to make, like, let's say, more divisions. If there is no antenatal steroids, I would suggest, I don't have an imaging, let's say lung ultrasound, I don't have it. So I suggested like to combine these two. So based on that, I would suggest an intervention. So if I'm above 400, so my non-invasive pressure support should be enough, whatever it is. When it's 350 to 400, I may suggest to increase the pressure support. But when I'm less than 350, I mean between 300 and 350, either way, here 350 to 400, I mean like to make the decision between less, but definitely less than 300, whatever the IO2, it's worth to give surfactant. I will move to the lung ultrasound. Lung ultrasound has 2 characteristics in its result. We'll get a score, and you have to get a description, which goes with the, for example, RDS. So prediction of surfactant need, in other words, prediction of CPAP failure. Based on this meta-analysis, lung ultrasound cutoff value of above 8 is very sensitive and gives like a kind of area under the curve, like, where's the AUC is 0.88, lung ultrasound alone. If you speak of the FiO2, it's good, not bad, but it's not the best. I mean the area in the curve is just 0.7. And we speak again about the variability. And here they use the FiO2 of less than 29%. By the way, the number of this FiO2 30% has come just like from one Australian study. They retrospectively examined 75 babies who received surfactant, and they checked on their FiO2, and they just suggested that FiO2 of 30% is a suitable point to make it as a cutoff value for the surfactant. I had the assumptions, okay, what score if I use the lung ultrasound? Simply just take from this that a score of 8, definitely yes, because there will be zones which are really, really severely atelectic and severely injured that require surfactant in order to be recruited. The presence of a zone of 0 makes RDS less likely. A score of 7 with this distribution can be worth of giving surfactant, but at the end, like it will be dependent on the other parameters. I know this may be causing headache, but I was trying to figure out, okay, why not ZORs? I mean, score of 6 is worth, because with the 1-1, that means there is good A lines, so it's easily recruitable lung, and the non-invasive pressure support should be enough. But when you speak of 2, one zone of 2, I can say it's still recruitable, but beyond 2 zones with 2, it might be difficult for a small baby to recruit the lungs even with the support from the CPAP. UltraSurf trial, it was a monocentric study randomizing surfactant administration based on the lung ultrasound versus the FiO2 threshold, and it concluded that babies who had the lung ultrasound done early before the 2 hours of age had surfactant being administered much earlier compared to those who are relying just on the FiO2. My second proposal based on the lung ultrasound finding was this one. If the baby is not intubated on a CPAP +7, do the SF ratio, and then based on the grouping of SF ratio, if you have lung ultrasound accessible, easily done, can be done without wasting the time, that would be good, and do it in all 4 pathways. But if you have it just limited, and you have an SF ratio less than 300, just go ahead, give less. You don't need that much of lung ultrasound, maybe. And you have 300, 350, you need the lung ultrasound. And the score I suggested, like above 8, as all the studies have shown, but I also added 7 if we have 2 more than 2 zones. If lung ultrasound less than 8, CPAP higher pressure can be enough to recruit the lung. 350, 400, almost similar with going up, I mean, either staying on the same pressure support or going to +8. When above 400, do lung ultrasound, it will support your decision, but if it's not easily available, just keep on the CPAP +7 and you can reassess the baby later. These algorithms are not one time. That's my suggestion, not to be done one time. It could be done on timing intervals. And I had some suggestions like to be done between the age of 1 hour to 2 hours, at 6 hours, and maybe at 24 hours of age. So suggesting timing to do this assessment might be also of benefit. Just for the chance, I was discussing this, and they have been working on this over the last 3-4 months. And I discussed even this presentation with Dr. Narvi, Hanifi, and Zina. And just next week, I have membership with this ESNIC website. They have the AAP recordings. And I was just attending this presentation by Dr. Francesco Raimondi from Italy about the lung ultrasound. And I found actually similar approach, relying on the SF ratio and the lung ultrasound, stratified based on the gestational age. The evidence they have raised, one of them is this kind of lung ultrasound for early surfactant. And they found that using the SF ratio with the lung ultrasound score increased the AUC, if we remember the lung ultrasound, from 0.88 to 0.97. It's very encouraging. This just like one of the diagrams they have shown, and that's justifies why it shows the 400 to 300 area, because all the slope phase is in this zone. That's why I divided between 400 to 350, 350 to 300, because here's the slope. Above 400, your likelihood of giving surfactant maybe not exceeding 5 to 10%. That's when you speak of the SF ratio. For the lung ultrasound, the slope starts with a +8. When you are at 8, the likelihood of giving surfactant is almost 10 to 15%. One of the studies that has been done, it was, this one is from Italy, done by Dr. Raimondi also, and included 240 babies. They stratified these babies based on the gestational age, 25 to 27, 28 to 30, and 31 to 33. And they just like did lung ultrasound for those babies and before the 2 hours of age. And they blinded the physician and left the physician to give the surfactant based on their own criteria. What they found that the babies, there was based, in addition to this variability, so let me just okay. There is variability in the time interval based on the gestational age. Like, for example, those who are 31 to 33, they received the first surfactant at 8 hours of age, while those who are 26 to 30 at 3 hours, while those who are smaller, 2 hours of age. There's also variability in the FiO2, which defined the need for surfactant with higher FiO2, given for those babies who are very small. Anyway, this trial has been revalidated, or let's say re-examined, rechecked, and they came up with this photograph, with this graph, when they combined the SF ratio with the lung ultrasound, and also they found it a much better with AUC of 0.93 when you combine the SF ratio with the lung ultrasound in predicting the CPAP failure and giving or providing surfactant. And based on that, they had some statistical work, and they designed this kind of website. I think if you like, I can show you how it works. It's just like you define the SF ratio. So you have 3 variables: SF ratio, lung ultrasound score, and the gestational age group. They divide it into these 4 groups. And you just click this and it will give you whether to give surfactant or no, don't give surfactant. And this is based on these 2 studies, basically. Recently, they are running a kind of validation in Europe about, and they call it the lung ultrasound oxygenation study protocol, which is combining the SF ratio and the lung ultrasound. They are just validating their information. So just like to again emphasize, this kind of calculator, which is available, accessible online, it's not yet for clinical use because their statistical, and their board review, they recommended to do a second validation before running it. But I think it's similar somehow to the algorithm I have suggested about the SF ratio of the lung ultrasound, although I did not stratify based on the gestational age. I just suggested less than 32 weeks. Okay. The last part is about the method of surfactant administration, discussion about pre-medication for MIST. So, speaking of Ensure, I included the Ensure in this study and in this survey. So what we are giving is the blue one. Only a third of us are happy with what we are giving, the high doses of fentanyl and high doses of succinylcholine. And that's why I invited the pharmacist actually to do this presentation and also to respond to the survey, thanks to some of them who responded. But there is some variability, and we can accept that. But speaking of Ensure, yes, you need some level of sedation. But my point is that there is some disagreement about what to give for those babies who require Ensure, full RSI or modified RSI. Speaking of MIST, most of us in the team, or those who responded, they agreed with atropine and small dose fentanyl between 0.5 to 1. Some of us, they are more in favor of no pre-medication. And actually some centers, they don't give pre-medication for the MIST procedure. My suggestion from this survey and from what we are doing, if we can just like make one agreement. First of all, for the pre-medication for airway management to have a kind of different protocol than this plain RSI. Our RSI doesn't take into consideration the gestational age and different metabolism. So we are giving this fentanyl-free microgram per kg for all babies and succinylcholine 2 milligram per kg for all babies. I think it should be justified based on the purpose, whether you want to do mechanical ventilation, and based on the gestational age or birth weight. That's my recommendation, number 1. Number 2, to have an Ensure specific route, which is, okay, I'm not against the fentanyl, succinylcholine plus minus. Some people, they don't feel comfortable giving succinylcholine and think that fentanyl is enough for this kind of procedure. It could be yes. All of us agree that we prefer Ensure for one thing, because the baby is well sedated, muscle relaxed, so I can intubate easily without this resistance and the movements of the baby. For the mist and Lisa, I would go personally, and based on this survey, and even with the survey I ran during the mini simulation, all the people are agreeing with a small dose of fentanyl, and maybe with this kind of steps. 0.5, another 0.5, just stand by. Now the technique, the catheter. All of us, we know that we have different kinds of catheters for surfactant administration. As I believe when I arrived here to Winnipeg, I found that the NGO catheter was the one which is predominantly used. And then I got to know that we had the surf catheter and we have the blessed catheter. And from the old Lisa description, they start to the feeding tube with or without Miguel forceps. Based on the survey, most of the people were in favor of the blessed cath and surf cath compared to NGO cath. And so either surf cath, red one, or the orange, which is, I called it the Lisa cath or the blessed cath. Less people were in favor of trying the NG tube or the NGO cath. NGO cath, honestly, all of us, we don't prefer it because it's difficult to manipulate in order to guide it into the glottis. Okay, for this question, which method you prefer depending on the gestational age, also, there was some variability, but I mean, there's clearly more inclining response to intubate, keep the baby on the ventilator for at least an hour for those who are less than 24 weeks gestational age. Some people, they are still okay with the surf cath and giving a mist, but half of us prefer to intubate and keep on the ventilator. Maybe the big concern is about the work of breath and the apnea and the respiratory drive. And this just changes dramatically with the 26, where people theoretically prefer the mist, but I mean, Ensure is the more predominant in our data, basically. And we can say that the mist goes up gradually, and it's the most preferred method, theoretically speaking. My suggestion for this is, all of us, we are practitioners, we have skills, we have defined skills, we have what we are comfortable with. And the first time I started the survey, my main goal was to define the comfort zone for each one of us. What's my comfort zone? It's okay to go with one strategy, with one method, with one kind of catheter, but please be open to the other different tricks, and because the differences are minor, but really the impact is very major. And always before giving surfactant to a spontaneously breathing baby, if you decide about it, just ask yourself, all the team, to ask the same question: why not mist? We should have kind of rationale why I don't want to give the mist. I want to go with the Ensure. I want to give, because we know that the most problematic thing with the Ensure, with the doses we are giving for the RSI, is the post-intubation failure to extubate, or let's say delayed extubation. And sometimes even a couple of hours of positive pressure ventilation. All of us, we know that there is evidence that this is harmful and has an impact on the bronchopulmonary dysplasia outcome. Our mini simulation was very simple. It did not take a long time. We had 8 participants in it. It was just like, would you like to do the mist with the different catheters we mentioned, whether you prefer to do slow surfactant installation or rapid surfactant installation. I will jump to the results. So this is the timing needed to perform the procedure for each of this, whether Miguel with NG tube, NGO catheter. You can say NGO catheter is the worst one, the surf cath or the blessed cath. For sedation, most of the participants required or preferred the fentanyl atropine. For the period of installation, most of us preferred a slow installation between 3 to 5 minutes. We had only 2 participants who preferred 1 minute. And actually, the original mist was with a slow installation, but recently some centers, they are doing it rapidly within 1 minute. And I'm concerned about the blockage that this bolus of surfactant may cause and when it's instilled in the trachea. After doing the simulation, what every participant would prefer to do, most of them answered with a surfacatheter, 2 with the blessed cath or the Lisa cath. So no more NG cath, no more NG tube is preferred. The specialized catheters are more preferred. I just want to notify that one of the participants, I'm not going to mention the name, had a record of 5 seconds inserting a surf catheter. I'm not going to declare the name. It's 5 seconds, only 5 seconds to give the surfactant. Okay, the average time, surfcath was the least time. So the average time required for the surfcath using or insertion was 10 seconds or almost 11 seconds. Then the bliss cath or the Lisa cath. NG cath and Miguel with NG tube had the worst or the longest. And this explains why we did not prefer it, why we had very low numbers, because we did not have the surfcath till maybe 8 months ago. My suggestion about of mist for the sedation, as I said, like for the mist is the atropine fentanyl half and half. Thin catheter, surfcath seems to be the most plausible thin catheter. NG cath is bad, it seems, and least preferred. Time of installation, most of the people prefer the slow installation. This was just like the infograph I tried to present during my info letter. It's just like to make steps of questions. Why to give the bless, discussing the criteria of giving the surfactant. Why not mist when you make the decision? And what, I mean, laryngoscope to use, the video assisted or not. Okay, I will finish. Why specific catheters? I have shown the results of our mini simulation and the preference of the surfcath and over how long it should be administered. And always, I know it's not in the guidelines, but always remember to give the caffeine before doing the mist procedure so that the baby suffers from the apnea less frequently. Final summary, my recommendations about having lookbooks for surfactants so that we can trace what is the best criteria and method for administering surfactant to learn from it, because I found a lot of difficulties in collecting my data. Having a proposed pathway, and that's why I proposed these two pathways with lung ultrasound available, and I don't think we will use this much, but maybe other rural area may use it. But for us with the lung ultrasound, and do lung ultrasound whenever you can, there's strong evidence that lung ultrasound you can say, make the decision faster, easier. It's not single one, don't rely on it alone. You have other things which can help you, like SF ratio. And I'm not ignoring the importance of the clinical severity and those things, but I think this combination gave the best, I can say, result. And if indicated, give the mist. And if you want to give surfactant by any method, try to protocolize your pre-medication for the mist, to use the steps I have mentioned about, and to use surfcath was the most preferable method. I think I'm done. Thank you so much. Any questions? I was hoping that the objections were raised during the discussion.
Ismaeil, I missed quite a bit of the presentation because I had some other things to do. Your presentation was amazing. Okay.
Thank you so much.
So hopefully I will be able to view it with my total concentration once Chris uploads it. But you know what? I mean, to me, it sort of blows my mind a little bit that surfactant became licensed in 1991. Okay, that is, wait a minute, 32 years ago. 32 years ago, yeah. I mean, and we still don't know, and that's understandable because there's different methods of doing things, but we still cannot come up with what is the best way of administering it. I think some of your suggestions are excellent. I think it means that what it implies is we all need to re-examine our thoughts, how we do it, when we do it, what is the best practice, and review our guidelines, which I may say the guidelines that probably are still in existence for giving surfactant. We had a lot of a debate about whether these were the appropriate guidelines. But we got sort of a consensus, which for certainly a few years were followed, but times have changed and we need to make sure that we have current guidelines in place. So thank you very much.
Thank you so much, Doctor. And actually, as I mentioned here in this slide, areas of variation are the areas of weakness. So the main cause for not having really a kind of better performance is that everyone is doing it in a different way. Even for the mist itself, the mist, just like one method, which is mist, is done different ways in every single center from one among us ourselves, like we are intubating. Every one of us like is doing something different. Speaking of brain medication, which catheter to be used, over how long period you want to do it. All of this variation actually, that's why I would love to have an agreement on something like a baseline and having something to trace and to track to see our improvement.
There are no questions, like, it's absolutely an excellent presentation and a great baseline, and also like Ismaeil had also looked up the the consensus guidelines that have come from the US less than a month and a half ago. So it's, I want to thank him for taking the initiative and presenting it in such a lucid way so that we can actually implement change. And so also I want to let everyone know this is his, like, as Ivan also knows, this is his last presentation. Like,
still, I don't know. I haven't got the visa.
Yet. So he's going to go. So let's all wish him best of luck for his visa, which is going to apply in a couple of days' time. And depending on that, like, will be his stay here in Winnipeg. So and as Molly mentioned earlier, like we are so proud of our fellows doing well, and then I'm sure he'll do even better in his career. We'll continue to track that along. Thank you, everyone. Any other questions from anyone at this point? There's a lot to digest, and then I'm sure that there'll be areas to move forward with.
I would like to take the opportunity to thank you as well. That was a wonderful presentation. That was excellent. And I think I echo what everybody's kind of thinking at the moment, including you, Ismaeil. I remember being in the rooms for like about 8 to 10 months with Molly and Nicole and Dr. Byer and Ruben, and it took a long time for us to try and figure out exactly how we would approach this. That was back in about 2000. Correct me if I was wrong, Molly, but I think that was 2008, between 2008 and 2010, when we were doing all this and going over it. But we didn't have lung ultrasound then. We didn't have the MIST methods and all the rest of it. And I think it is absolutely warranted for us to relook at this and rethink about it and get something down again on paper that everybody does and we do more consistently. The more consistently we do it, the better we do it, the better it is for those babies.
Definitely. Thank you so much, Ron.
So I would just emphasize on the same thing that this was a great presentation, Ismaeil, and thanks a lot for preparing this intensive review, which is great. I think we probably would be speaking to the US Embassy to keep you for a while, although this is not the best for you, but we really, as Ganesh mentioned, we wish you all the best, and you will definitely be missed. As Bron mentioned, and I think as all the people, I think this was very intriguing. We need to do lots of things, although we need really people to take or to own such projects. It is not like it shouldn't be a one-man show or the fellows project or others, but I think we should initiate systems that would adopt seeing our practices and actually work on improve it continuously, whether it is for surfactant administration or for other things. I just wanted to ask you about with review and using the lung ultrasound for prediction of surfactant. I think I know that most of the literature used a score of 8 or above. I know some literature used 9 and above, but did they all do lung ultrasound within the first 2 hours or the timing was different?
As I remember, all of them, even this one above 9, the score above 9 was done within the first 2 hours of life. Yes, that's why I remember it was done in the first 2 hours of life. Yeah, I mean, like that's what I remember from reading all of those trials. This one was using the lung ultrasound above 8, but I was reading one about the cutoff of 9. That's why actually one of the things I did, okay, why they are choosing the things based on results. Let's just take it physiologically. If I have scores of 2, more than 3 zones, So the score definitely will be above 6, so 7, 8 or something. I found 8 is more plausible, although some 8, like this one, for example, is like, you can say 2/3 of the lungs is easily recruitable. You can try 7 or go up to pressure 2. So that's why, for example, here, I recommended maybe pressure or bliss. It could be recruitable. But when you have more than 2 zones, which is half of the lungs, half of the lung fills, is up 2 and above, I mean, it might be difficult for, it's just like the common sense in approaching it.
Yeah.
But yeah, some of them is like, yeah, using the score of 9 compared to 8, but it's definitely above 8 and above.
Thanks a lot, Ismail.
And talking about like taking some action, actually, I discussed this presentation even with Nico, and I think she's leading the lung health committee. And I would love to share with her all the data I have and this presentation itself so that they can build on it, like some kind of clinical practice guideline for our sites, both sites, HSC and St. Boniface, hopefully.
This definitely would be great.
Thank you.
Hi, Ismail. It's a nice presentation. I'm just
Thank you.
wondering, because in SPA conference last year, especially in European group, mainly from Germany, they showed beautiful video, even since in the delivery room, they use propofol 1 milligram per kilo IV, 1 dose instead of fentanyl. And
Yeah.
they showed the years, there is no remarkable changes at all, nothing, no blood pressure changes. So have you gone through anything details on the propofol, any other articles that is spreading?
Actually, I'm one of the fans of propofol. I like this medicine when I was in the PICU. You don't
I
need to
must
give.
have because of PSC background, yeah.
Yeah, and that's why I suggested this during like the survey, but I think only one of the respondents agreed with the propofol. I remember in 2018, there was some kind of small trial, but it showed like higher risk of having adverse events with propofol. So far, there's no strong evidence that it's very benign, but as a practice, as we do with the chloral hydrate, we are happy with the chloral hydrate for us, but still you don't have that strong evidence it's a very benign medication or something that, I mean, strong evidence that, okay, anyone will claim, okay, why do you use chloral hydrate for newborns? And you don't have that strong evidence.
I mean, I just mentioned that, you know, of course we can explore that, but the main concern with propofol was prolonged and sustained problems with blood pressure
Exactly.
in newborns, and that's been studied as recently as 2020. So that's the one concern where how will it respond to in this part? So it still needs some time to validate. And 2 bads, I agree with you with chloral hydrate. 2 evils don't make a good necessarily make a good thing. Like, yeah. So prolonged and sustained hypotension is a concern. Yeah. And that's bad for the brain. Yeah.
Okay. I don't know if there's any more questions.
Thank you very much. I think
Thank you
it's
so much.
we'll close for now,
done.
and thanks again.
Thanks, everyone. Thank you.
Thank you very much.
Thank you. Thank you, Doc.
Thanks.
Thank you. Thank you.